شكرا دكتورة ريهام. بحب أشكر وبأهني دكتور أستاذي الدكتور هشام عوض، دكتورة نهال، دكتورة صفاء، دكتورة رانيا ودكتورة علا. أشكرهم وأهنيهم على المؤتمر، وبقدم الدكتور عاصم عبد اللطيف أستاذ مساعد Neurosurgery هيكلمنا عن Management of Neonatal Intraventricular Hemorrhage and sequelae Neurosurgery Perspective. اتفضل حضرتك.
صباح الخير. أنا اسمي عاصم منير عبد اللطيف وأنا لسه مدرس يعني. خلاص بشرة خير إن شاء الله. أنا اسمي عاصم منير وأنا يعني بشكر طبعا الأورجنايزنج كوميتي والساينتفك كوميتي والدكتورة منال ودكتور هشام على extending الانفيتيشن ليا ان انا اكون موجود معاكم to share يعني in this meeting، لان طبعا يعني ده من منطلق الاندرستاندينج ان المالتي ديسيبلينري ميتينجز والتيم ديسكشنز بتبول experience into the patient's outcome. انا احب على طول اوصف علاقتي بقسم الاطفال على انها علاقه يعني مستمره وجميله. انا يعني علاقتي مستمره بقسم الاطفال من بوحداته المختلفه. دكتوره جليله بتعبها معايا شويه في التيومر بوردز وفي الديسكشنز، ودكتوره مروه ودكتوره ايمان رجب. وبرضه يعني احنا يعني ممكن سمعتنا مش احسن حاجه في النيكيو، يعني بنتعبهم شويه في الانترفنشنز، بس هو الهدف ان احنا يبقى عندنا common grounds والاندرستاندينج، لان فعلا جزء كبير من الديسكشنز بتبقى based على يعني different perspectives يعني. يعني without further ado انا بس يعني هنتكلم على المانجمنت of intraventricular hemorrhage وال post intraventricular hemorrhage sequelae from our perspective. هو يعني to start with طبعا the source of intraventricular hemorrhage or neonatal intraventricular hemorrhage could be the germinal matrix, or it is the germinal matrix. Germinal matrix is found in the thalamo-caudate fissure or between the thalamus and the head of caudate in the developing brain. With this provides glial elements and neuronal elements to both cerebral hemispheres. It's a highly vascular structure, and its vessels lack the regular or the usual autoregulation of the full-term baby. So autoregulation has limited range in the healthy preterm, and virtually there is no autoregulation in or cerebral autoregulation of the vessels in the germinal matrix in a sick preterm. And this definitely is the cause of the neonatal intraventricular hemorrhage or the intraventricular hemorrhage in this pediatric age group. Source of bleeding يعني كان في debates كتيرة عليه، أو يعني early assessment or early studies coined venous hypertension or venous stenosis as the cause of the neonatal intraventricular hemorrhage because of the the acute angle of the thalamostriate vein and the caudate vein. This at the area of the venous drainage of the germinal matrix could be a cause of this intraventricular hemorrhage. Subsequent studies showed that it could be related to capillary bleeds or arterial bleeds, and definitely it's a mixed etiology. The risk factors for the development of intraventricular hemorrhage could be definitely prematurity. It's found in 25 to 30% of the kids with preterm diagnosis, and with an increasing incidence in the low birth weight and the extremely low birth weight. Patients with pneumothorax, even if they are full term with pneumothorax, respiratory distress, placed on mechanical ventilation, high frequency, or who received vigorous resuscitation or developed seizures, neonatal sepsis, all these are risk factors. These risk factors have something in common. They increase the perturbations and the fluctuations in the cerebral blood flow, either increasing the venous pressure or increasing the arterial blood pressure. And fluctuations have been shown that ischemia in the germinal matrix followed by vigorous resuscitation and subsequent irrational volume overload could be resultant of, or could be causing the intraventricular hemorrhage. Germinal matrix hemorrhage in this context, germinal matrix hemorrhage in this context could be also associated with a reperfusion. Could be associated with a reperfusion injury in patients with fluctuations of the blood pressure with the initial hypotension followed by hypertension, they could have breakthrough bleeding causing the periventricular hemorrhage. No intraventricular hemorrhage, no talk about intraventricular hemorrhage or presentation would not mention the famous classic Papier classification. With a grade 1 of subependymal hemorrhage restricted to the subependymal area or even minimal breach into the ventricular compartment, a grade 2 extending into the ventricle but not causing hydrocephalus because it doesn't occupy more than 50% of the volume, and a grade 3 causing hydrocephalus. Grade 4 was initially described as periventricular area of hemorrhagic necrosis because of the venous etiology, but then subsequent pathological specimens and studies showed that this could be also reperfusion related injury. This group from Liverpool, they showed that there was sort of a declining overall incidence of the neonatal intraventricular hemorrhage, but still retaining severe grades of intraventricular hemorrhage in the younger gestation. They had mentioned also that the data are scarce from the low middle income countries, and the confounding variables would also limit the extrapolation of the data from these studies because of we have different patient factors as infection, the fetal viability threshold is different. They're talking about 23 weeks of gestation and we're talking about 28 weeks. In terms of, from our perspective, what are from the neurosurgery perspective, sequelae of intraventricular hemorrhage? When a kid develops intraventricular hemorrhage, he definitely wouldn't go as normal as expected because the germinal matrix, which is the source of the glial and the neural elements for both cerebral hemispheres, would be destroyed or severely affected. And this definitely would affect the myelination, the subsequent brain growth and cortical development. But the major concern, or the famous concern, is the development of post-hemorrhagic hydrocephalus, which develops in 25 to 50% of the premature babies with a 3 to 4-fold increased risk of cognitive and psychomotor delay. The hydrocephalus in this context could be developing in 2 forms. The first one is acute form with the diagnosis, concomitant with the diagnosis, the ultrasound diagnosis of intraventricular hemorrhage. And this could be due to the clot obstructing the foramen of Monro or the aqueduct of Sylvius, or in a delayed fashion, which develops 1 to 4 weeks after the diagnosis was established by ultrasound or transcranial ultrasound. This could be either due to the excited ependymal reaction causing adhesions, fibrosis, synechia, and obstruction, or due to obliterative arachnoiditis that causes absorption defect in the subarachnoid space. The development of manifestations or clinical manifestations in these kids is somehow elusive because the development of divergent macrocephaly, the bulging anterior fontanelle, the apneas and desats are somehow inherent. Apneas and desats are somehow inherent in the premature babies, but the development of the fontanelle, the bulging of the fontanelle and the divergent macrocephaly could be delayed. And subsequently, this could harm the brain, the developing brain. Basically, this is because the brain in this kid has, or this child has a large water content or a proportion that accommodates the expansion in the ventricular compartment and subsequently doesn't reflect on the occipitofrontal circumference except lately. And also the subarachnoid space is plump and it could be compressed until this reflects later on the occipitofrontal circumference. This undermines or underscores, the importance of serial scans in these patients, serial ultrasound to document progressive ventricular dilation or compression, and also to measure the resistive index and an accurate reflection of the intracranial pressure. The single most important intervention that has proven efficacy and improved prevention of the development of intraventricular hemorrhage was the antenatal administration of steroids. And here in this systematic review that was published in 2007, updated in 2017 and 20, they included 30 studies, 30 RCTs from the Cochrane collaboration, and they found that the relative risk with administration of steroids was 0.55 with good quality or with moderate quality. Another article or another retrospective multi-institutional study by Jeffrey Perlman and Walid Salhab. They reviewed 124 patients with prematurity, and they found that the administration of steroids also had a dose-dependent effect on the development or the incidence of intraventricular hemorrhage, the respiratory distress, and the cognitive and psychomotor development. Whenever we have a child with intraventricular hemorrhage, there is a natural tendency to immediately intervene with this patient. This is from the neonatology team and also sometimes from the neurosurgery team. That's how conflict comes up. Because the neonatology team, they want immediate intervention because they want the best circumstances for the developing brain. They don't want to sit on something conservatively. They don't feel comfortable having a kid with neonatal intraventricular hemorrhage with a grade 3 or 4 with hydrocephalus and just do nothing. But the natural, some of these patients or most of these patients may have a ventricular dilation under normal pressure, and this is slowly progressive. Understanding natural history reports showed that 50% or around 50% of these patients may cease progression or resolve within 1 month without any sort of active intervention. But the other half would definitely show progression, and this is an unequivocal indication for intervention. Still, pathophysiology of the persistent or the progressive post-hemorrhagic ventricular dilation is complex because of the presence of a CSF volume could increase the intracranial pressure, and an increase in the intracranial pressure would subsequently affect the development or have a negative effect on the growing brain. But on the flip side of this, an increase in the CSF volume will facilitate the CSF absorption through a pressure-dependent mechanism. So balancing these pros and cons is a key point in understanding how to manage these patients and not to rush into surgery, because surgery or interventions may have a lot of complications in these patients. What could we do in patients with neonatal intraventricular hemorrhage? There is a whole myriad of options, starting from doing nothing, conservative management, serial follow-ups, and sometimes prescribing Siramax or acetazolamide to decrease the CSF production just to ameliorate the negative effect of the hydrocephalus and the increased CSF volume on the brain. Others may have the idea of doing lumbar punctures or serial lumbar punctures, putting an access device, CSF taps, but lumbar punctures is a very famous intervention for these patients, and it was pioneered and still I don't think it's no longer advised by Andrew Whitlow from Bristol because he just conducted this systematic literature review in the Cochrane collaboration, first in 2000 and October 2000, then updated in November 2009, and then in 2017, and still it delivers the same message. They looked at the neurocognitive disabilities and the occurrence of post-hemorrhagic hydrocephalus, shunt dependence, and overall mortality, exposing patients to kids with intraventricular hemorrhage and prematurity to serial lumbar punctures, or doing nothing. They included 4 control trials, and the main results was that compared to the conservative management, doing nothing, the relative risk was very close to 1, and there is no statistically significant benefit of the repeated lumbar punctures. Still, there was some growing evidence that it has an increased risk of CSF infection, and so they cannot recommend this. And this shows that the pooled evidence is harboring or straddling along the line of no effect. So it is not that recommended based on their review. And it stood the test of time because on their recent review, they excluded 1 of the 4 control trials that they previously analyzed because they reported shunt outcome as placement of shunt and also the placement of Ommaya reservoir. So they included this from the outcome assessment to avoid confusion. And they found that still there is no added benefit of the serial lumbar punctures. These are different modalities of management. We're familiar with the Ommaya reservoir, basically for the intraventricular and the intrathecal chemotherapy, but the ventricular subgaleal shunt, that's another thing. It's like the Ommaya reservoir, but it has a distal catheter that is placed in a subcutaneous tunnel or a subcutaneous pocket in the scalp. And it definitely produces this sort of collection in these kids. So we have an option of either the ventricular access device, which is the Omeyer Rickham reservoir, different markets, and the ventricular subgaleal shunt. They share the same basic concept, is that removal of blood clots, blood degradation products, and cytokines would help improve and avoid systemic, inflammatory response in the brain and in the ependyma and in the subarachnoid space. And this definitely would have a favorable effect, or in theory would have a favorable effect on the development of shunt dependence later on. But they differ in the rate of the absorption. The ventricular subgaleal shunt is a low pressure continuous decompression or continuous drainage of the intraventricular compartment or the CSF, but the Omeyer reservoir depends on repeated taps and intermittent drainage. These are different concepts, but comparing them, in 2009, John C. Wellens and from Salt Lake City, they looked at a retrospective review of patients, retrospective analysis of their patients in the NICU, and they found that the Rickham reservoir or the ventricular access device could have a less incidence of later shunt dependence over the ventricular subgaleal shunt with comparable results. But then the fellows at St. Louis University, they compared the ventricular subgaleal to the Omeyer reservoir, and they found that they have comparable results. There was no statistically significant difference, and they had the similar complication rate because there was a concern about the skin breakdown, the infection rate, and the wound dehiscence when we use the ventricular subgaleal shunt, and it develops this big collection in the scalp of these premature kids. I didn't mention the shunt in these patients, in early patients, in the development or the control of the progressive post-hemorrhagic hydrocephalus in preterm babies, because they're compromised, they're vulnerable, they could have a skin, very thin subcutaneous tissue, and also it has an established risk with necrotizing enterocolitis if we implant a ventricular peritoneal shunt early on. The other thing is that neurosurgeons do not prefer to put in a shunt whenever the CSF is still hemorrhagic and it's not that clear. We wait until it becomes clearer and favorable for the shunt insertion. So we use the ventricular access device or the ventricular subgaleal shunt as a temporizing measure until we find if this child would require definitive shunting later on, or he would go or pass on without shunt dependence. Another thing given to us or handed to us by the development of technology and digital technology is the endoscopy. The images of intraventricular endoscopy is now superior, and the safety profile of the use of endoscopy has given us the advantage to and the courage to do different options using the endoscope. We can do the endoscopic third ventriculostomy if we find that the later hydrocephalus that requires treatment has an obstructive pattern. If there's multiloculations which could develop and develops very commonly, we may do endoscopic fenestrations and then put in a shunt if the kid has clinical manifestations that require shunting. And if the pattern is communicating or unclear, there is a growing trend to do endoscopic third ventriculostomy and choroid plexus cauterization, because it has documented and showed an increase in the success rate with these patient groups. This is a group from Italy, Giuseppe Sanelli. He had a small cohort of patients, so 18 patients, mostly grade 4 intraventricular hemorrhage, and they used ventricular access device or Omeyer reservoir on all these patients. 82% of them, they required subsequent treatment with shunting, but they ended up doing shunts, ETVs, revisions of shunts, doing revisions of ETVs or endoscopic third ventriculostomies, and 59% of these patients were shunt independent. Getting a patient or a child treated with 4 hydrocephalus without a shunt is definitely a good or a huge success for a pediatric neurosurgeon, because complications of shunts as infection, malfunction, obstruction, and the shunt dependency itself is something that's troubling to the pediatric neurosurgeon and the child's family. And there's another thing, which is a very strong evidence of coming from a randomized controlled trial of the brainwashing or the drift, which is the drainage, irrigation, and fibrinolytic therapy from Andrew Whitlow again at Bristol. They did a multi-center RCT with recruiting 70 patients, and they compared this drainage and irrigation to the standard treatment, which is just either follow-up or repeated lumbar punctures. And they found that the drift versus standard, they didn't offer additional benefit in terms of the later shunt dependence. This was discouraging at first, but recently they found, and I had this article handed to me by our colleague here, Dr. Assoa, and we discussed doing this lavage or irrigation of the ventricular compartment to get rid of the blood and blood degradation products. Doing this with a catheter, doing this with endoscopy, the basic concept still stands, but it showed something without evidence that survival without cognitive disability was 66% in the kids who had lavage and 35% with standard treatment. So this was the long-term analysis of these patients on neurocognitive development, and it coined something that this was the first intervention for post-hemorrhagic ventricular dilation to objectively demonstrate sustained cognitive improvement. This is my last slide. At our department at Ain-Shams University, we started 2 clinical studies to demonstrate or to test the efficacy and the safety of the neuroendoscopic lavage, but for the CSF infection and ventriculitis, because when we did a prospective registry of pediatric hydrocephalus or the patients with hydrocephalus who are treated at our department at Ain-Shams University, we found that the majority were in the spina bifida and the Chiari type 2 associated hydrocephalus. And then the next instance or the next common etiology was the post-infectious hydrocephalus. Post-hemorrhagic hydrocephalus was not that commonly or didn't present that commonly in the registry. So we started with the CSF infection ventriculitis, and then we can extrapolate this to the management of post-hemorrhagic hydrocephalus if the results were encouraging. And also we're implementing the outcome of the CURE protocol, which includes the ETV and choroid plexus cauterization as a primary treatment for infantile hydrocephalus. Kids under 2 years, they have problem with shunting. We see the problems with shunting, repeated shunt infections, malfunctions, and obstruction of the shunt dependency is something that's really bothering us. And so to get rid of a shunt and do endoscopic third ventriculostomy is something that we need to tackle more elaboratively. That's my last thing, and thank you so much for your time and for listening.
شكرا جزيلا استاذ دكتور عاصم، جزاكم الله خيرا. والان موعدنا مع اخونا الفاضل الاستاذ دكتور هشام عوض لالقاء كلماته الكريمه في المؤتمر بتاعنا، وبشكره على جهده في تنظيم المؤتمر مع الاستاذه الدكتوره نهال وكل الاخوه المشاركين في